This is a 55-year-old gentleman, a man in his most productive time of his life to our society, who have no significant past medical history, but started complaining the B symptoms, such as weight loss and non-sweating. And so he was diagnosed with mantle cell lymphoma. His lymphoma, I think, is high risk because he has a 9-centimeter mass in the abdomen. And then the cyclin D1 was positive. Cyclin D1 is pathognomonic for the diagnosis of mantle cell lymphoma. You have to have either 11-14 translocation or cyclin D1 in order for you to diagnose this is mantle cell lymphoma. The patient has both. He has translocation 11-14, and he also has cyclin D1 positivity. Very, very importantly, his cyclin CD20 is positive. As we all know, CD20 is one of the most important immune markers for our therapy with the rituximab. So CD20 in this case is also described to be positive. Those all are very consistent with mantle cell lymphoma diagnosis. So after the diagnosis, the patient was staged, and because there's no bone marrow was done, he was stage 3, which I agree with the stage. This patient, in my opinion, has a moderate to high risk disease because the MIPI is high, over 6, and also there's a bulky tumor in the abdomen up to 9 centimeters. So those are all bad prognostic features. So if this patient is treated with a standard therapy, such as hyper-CVAD followed by autologous stem cell transplant, we call the Nordic therapy. The Nordic therapy is induction therapy followed by frontline autologous stem cell transplantation. And in this case, the induction therapy varies according to different versions of Nordic therapy, according to the interpretation by other colleagues in America. So some people use DHAP, DAP, some people use bendamustine rituximab, and a lot of people use hyper-CVAD, followed by stem cell transplant. So although the inductions vary, the universally used is the stem cell transplantation. So this patient was treated according to standard care. Of course, referring to standard care, there's no such a thing as standard care in mantle cell lymphoma because it's such a rare disease. Phase 3 clinical trials are almost never done, but they are coming, by the way, but so far in the history, never performed. Some people use Nordic therapy. A lot of American colleagues who are specializing in mantle cell lymphoma use 6 to 8 cycles of hyper-CVAD without the Nordic autologous stem cell transplantation. The hyper-CVAD is the MD Anderson method of treating mantle cell lymphoma. The hyper-CVAD was developed for mantle cell lymphoma from MD Anderson. So this patient was treated with standard care, achieved a good response.